Assalamu alaikum and good evening. Welcome you all to our regular Zoom-based gynecological oncology session, which is organized by the Oncology Club of Bangladesh. We regularly arrange this session in every Tuesday, and alternatively, we are presenting the either tumor board or the lecture series in gynecological malignancy. Today is the last day of our cancer service, the lecture series. And our faculty today is Dr. Shoilosri T. Shurappa. She is I will introduce her before her presentation, and she is the professor and a consultant gynecologist, Tata Memorial Hospital, Mumbai. And our presenter today is from Dhaka Medical College Hospital, Dr. Lutfa Begum Lipi, and another faculty is Dr. A.K. Goodman. Unfortunately, our president of the Oncology Club, Professor Dr. M.A. Heiser, he is sick, and so he cannot join the session today. So I request our scientific secretary of Oncology Club, Dr. A.F.M. Kamaluddin Bhai, to give us permission and please highlight something about the Oncology Club. Yes, because our today's faculty is new. She is another professor of gynae-oncology in Tata Memorial Hospital, and she is renowned gynae-oncologist from Tata Memorial Hospital.
Assalamu alaikum. Good evening to everybody. Welcome you all to our regular gynae-oncology session. So Oncology Club is very proud to be the host of this such initiative, and we are grateful to the all gynae-oncology colleagues of Bangladesh who are carrying this program forward. So I'm very happy that today we are welcoming our old friend Catherine from Boston, but also we are having a new friend, that is Dr. Shoilosri from Tata. So welcome to Dr. Shoilosri. Tata is a old name and known name to us, but maybe you are a new name to this program, but not a new name to our community, as I understand. And I'm sure you will be enjoying the session and we will be enlightened from your presentation and interaction, because in this platform, we always believe that all of us are learning from each other. And what I request will be that keep on supporting us, be with us, help us to proceed forward, because our objective is to offer a good treatment, optimum quality of care to cancer patient, because cancer patient deserve the best irrespective of its location and boundary. And this is how in this virtual platform, creating a global endeavor to give the best. Thanks Dr. Shoilosri for joining, and thanks to Catherine as always, being with us. You people are the strength of Shahana, who is carrying this project, and she is doing the impossible thing possible. So without wastage of any time, I'm sure that today we are going to listen to a wonderful presentation from Dr. Lutfa, who is a brilliant gynecologist of our country. And Shahana, you can start your program.
Thank you, Dr. Kamal Bhai. Before starting our program, we have the regular, the polls question session. Now I request Dr. Fatima Shorna to show your poll questions. Beginning of the session, we'll show you the poll questions, and every participants are requested to answer the poll questions. And at the end of the session, again, it will be shown, and among them, 3 participants will be selected as the lucky winner. And all 3, at the end of the session, all 3 will be selected and all 3 will be given the award. So please participate in our poll question. Shorna, please.
Yes, ma'am.
So during the poll session, that just for Shoilosri, our Oncology Club was formed in 1996. The founder was Professor ABMF Karim. He was emeritus professor in Free University in Amsterdam. And he was the first Royal College Fellow of Radiation Oncology in total Indo-Pak subcontinent. And the second was Sharaj Gupta from Calcutta. So Sar was the first person from this area. But when he retired, he came back to Bangladesh and he formed this Oncology Club. And from inception till today, our main focus is for manpower development. We are not looking for making a hospital or doing many primary care, but we are always believe that we need to get trained manpower to offer the best treatment. So that's why from the beginning we have been doing it. We do local programs, we send people for overseas training, and we believe that it is better to bring faculties like you to home than sending people to your places, because get trained in our own environment is the best secret of success.
Yes. Yes, I think capacity building is the most important for all the developing countries, all of us, India, Bangladesh, Pakistan, and also Sri Lanka. I think we are struggling with quality assurance and capacity building in our countries. And I think it's not the guidelines, it's not the knowledge, it's just that capacity building which can serve the population. I agree with you completely. That's what we need.
Thank you, Shaileshri. So we were fortunate to have all the friends from TMH supporting us. And today I'm very happy to have a new face in the list. And I'm sure we will be moving forward with more strength, because we are fortunate that not only from the region, you can see all over the globe, we are getting the supports. So this is how we will be moving forward. And I think Anna Catherine Goodman. She is a good friend of us,
Okay.
who was fall in love in Bangladesh since she first visited in 2007. And then she developed a habit of visiting us and helping us.
Very
So now we are using that habit of Annie Catherine Goodman and trying to use the resources and move forward.
That's nice. That's nice to hear.
So Shahan, you have a participant from Bhutan. Dr. Yugen
Yes,
is
yes.
here. So we are
She's co-host.
expecting the Prime Minister of Bhutan also in Bangladesh,
Yes.
and we are happy that Yugen joined on the same day when our Prime Minister will be visiting.
Yes.
So
Also,
thanks
she-
again for joining.
Yeah, thank you.
Poll voting completed?
Yes, ma'am.
Yes. Now poll voting is completed. Now I request our gynae oncology resident, and she is Dr. Lutfa Begum Lipi from Dhaka Medical College Hospital, to present to give her presentation. Dr. Lutfa, please.
Respected chairpersons, distinguished guests from home and abroad, and my respected teachers and learned audience, Assalamu alaikum and very good evening. We are celebrating the Golden Jubilee of our Independence Day, and 26 March is the Independence Day. We humbly show our respect to all the sacrifices to gain this achievement, and we are living in an independent day, Bangladesh. And here I am, Dr. Lutfa Begum Lipi. Welcome you all on the Oncology Club organized a lecture series on carcinoma cervix, and I am going to present on surgical management of cervical cancer. I am working in a gynecological oncology unit of Dhaka Medical College Hospital as an assistant professor. As it is a lecture series, and in the previously there was 2 lectures already have done, the diagnosis and staging of treatment of cervical cancer and non-surgical management of cervical cancer. And today I am going to present the surgical management of cervical cancer. The treatment modalities of carcinoma cervix are the surgery, radiotherapy, and chemotherapy. And the treatment involves the appropriate management for the both primary lesion and potential sites of metastatic disease. But the surgical treatment is usually limited to the stage 1 and early stage 2A stage. If we go through the 2018 FIGO classification, the stage 1 and stage 2A, the stage 2, in these 2 stages, we can manage by both surgery and radiation therapy with equal cure rate. Stage 1A, it is the microinvasive stage. It was first introduced by the Messwort in German literature 1947, which was divided into 2 sections. It's stage 1A1 and stage 1A2, where stage 1A1 is invasion is 3 millimeter, and the stage 1A2 is more than 3 millimeter, but less than equal to 5 millimeter in depth. And it was diagnosed by by small punch biopsy can be diagnosed it, but definitive diagnosis of microinvasion can be made by conization. So primary treatment of the stage 1A1 cervical cancer depends on the result of cone biopsy and whether the patient wishes to preserve her fertility. A cone biopsy with clear surgical margin and a negative endocervical curettage should be considered adequate treatment. And here the treatment observation is an option. When the cone margins of the post-conization endocervical curettage reveals high-grade dysplasia or microinvasive carcinoma, a repeat conization should be performed before proceeding to simple hysterectomy or further advanced surgery. The factors that significantly affect the risk of the residual disease includes the positive post-conization ECC, positive cone margins, depth of stromal invasion if more than 1 millimeter. Trachelectomy, pelvic lymph node dissection, sentinel lymph node mapping, and extrafascial hysterectomy are the treatment options where the women are not wants any childbearing, and in case of postmenopausal women, because in this group of patients after conization, stenosis of the endocervical canal limits the ability to obtain the ECC. In stage 1A2, the incidence of positive lymph nodes 3.2% and the death from the disease is 1.8%, which is low when the horizontal spread is limited to 7 millimeter. So in this stage, group of patients are treated with modified radical hysterectomy and pelvic lymph node dissection. But sometimes patients are young and wish to preserve their fertility, then radical trachelectomy and pelvic lymph node dissection is recommended. But when the medically inoperable patients who are refused surgery, pelvic external beam radiation and brachytherapy is a treatment option. The stage 1, B1, B2, and stage 2, A1. These are the ideal case for radical hysterectomy and pelvic lymphadenectomy with or without para-aortic lymphadenectomy. These are the equal cure rate which is obtained by primary radiation therapy and concurrent chemoradiation. But surgery itself has an advantages. Like this is removing the tumor, allow the accurate surgical staging, allow adjuvant therapy to be more accurate, avoids possible radiation damage to bladder, small and large bowel, and the vagina that cause the sexual dysfunction when the both EBRT and brachytherapy causes the vaginal atrophy, fibrosis, and stenosis. In stage 1, B3 and stage 2, A2, traditionally the advanced diseases includes the stage 2B, 4. However, many oncologists now consider these two stages are advanced stage category. Now, some points about different type of surgery. First of all, the cone biopsy. Conization of the cervix or cold knife cone is a surgical procedure used to treat or diagnose cervical dysplasia and microinvasive cervical carcinoma. It is the excision of a cone-shaped portion of the cervix to remove a cervical lesion and the entire transformation zone, which can be removed by a surgical knife, a scalpel, a carbon dioxide laser, or loop electrosurgical excision procedure. But the steps should be in the, it can be done in general anesthesia or the spinal anesthesia. Blood loss is minimized by prior hemostatic sutures at 3:0 and 9 o'clock positions on the cervix by ligating the descending cervical branches. The cone is cut so as to keep the apex below the internal os. And after the cone is removed, the margin is sutured at the 12 o'clock position for identification of the cone and to identification of the lesion, which can help our histological colleagues to identify and diagnose the actual case. Cone biopsy can be done in some diagnostic and some therapeutic purpose. In diagnostic purpose, this is suspicious for adenocarcinoma or adenocarcinoma in situ of the cervix, where there is a histological discordance with the cytological screening test and histological results. When there is a unsatisfactory colposcopic evaluation with evidence of dysplasia or unexplained high grade or an atypical glandular cell cytology, or when their interrelation is not completely seen by colposcopy. And in the treatment purpose, it can be adequately treat the severe dysplasia and stage 1A1 squamous cell cervical carcinoma if the patient wants to maintain her fertility. But we should think about some disadvantages, like the abnormal tissue at the margin of the normal tissue after cone biopsy can be changed by heat from the laser beam or the wear loop. This can make the laboratory study of the biopsy tissue more difficult. Another point, the healing and scarring process after the cone biopsy may make it hard to identify the abnormal tissue in the future. And sometimes cervical stenosis can cause the infertility. We are doing this to prevent the fertility. So sometimes it can done in the adverse event in the pregnancy outcome by increased risk of miscarriage and preterm labor due to incompetent cervix. In 1994, Dargent et al. Pioneered the use of radical trachelectomy vaginally and laparoscopic pelvic lymphadenectomy. After that, radical abdominal trachelectomy was first reported by the Smith, and it is more familiar because we are more familiar with the abdominal route. And it is also known as cervicectomy, and it is indicated in the early stage cervical cancer. As the uterine body is preserved, this type of surgery is a fertility-preserving surgical alternative to a radical hysterectomy and applicable to selected younger women with early cervical cancer. But it should be think about that fertility can be impaired by cervical stenosis, adhesions, decreased cervical mucus secretion. The steps are after the uterine artery ligation and the ureter deroofing with its uteric tunnel, the parametrium, paracorpus, and the upper 1.5 centimeter of the vagina is resected. Separated the corpus and the proximal cervix from the bulk of the cervix and upper vagina. After that, a surface suture was placed around the cervix and the upper vagina. In 1974, Tumour et al. Described 5 types of hysterectomy for the cancer of the cervical cancer. Type 1, the extrafascial or simple hysterectomy. Type 2, modified radical hysterectomy. Type 3, radical hysterectomy. Type 4, extended radical hysterectomy. And type 5, that is the partial exenteration. And the first 3 are the more popular and more practiced for the treatment of surgical management of cervical cancer. Some points about different types of hysterectomy. It is the type 1 or extrafascial hysterectomy. This procedure is for the stage 1A1 cervical carcinoma without involvement of the lymphovascular space involvement. It consists of removal of the cervix and adjacent tissue as well as small cut-off cuff of the upper vagina and in plane outside the pubocervical fascia. Minimal disturbance of the uterus and the trigon of the bladder. The modified radical hysterectomy is known also the Wardim's hysterectomy. It removes the cervix, proximal 1 to 2 centimeters of the vagina and parametrial and paracervical tissue. This hysterectomy is well suited for the tumors with 3 to 5 millimeter depth of invasion and smaller stage 1B tumors. The radical hysterectomy, that is known as type 3 hysterectomy, requires greater resection of the parametria and the excision extends to the pelvic sidewall. In addition, at least 2 to 3 centimeters of the proximal vagina is resected, and it is performed for larger stage 1B lesions and stage 2A lesion. Type 4 is type of extended radical hysterectomy. It's removal of the all periureteral tissue, supravesical artery, and upper 3/4 of the vagina is included. In type 5 exenteration, the terminal ureter or a segment of the bladder and or rectum is removed along with the uterus and parametria. There is some differences between the Wardim's or modified radical and radical hysterectomy, and the two doctors, the Litzko and Okabayashi, has discovered or described some spaces, that is paracervical and pararectal spaces. And there is some modified, some differences between the Wardim's hysterectomy and radical hysterectomy, that in the Wardim's or modified radical hysterectomy, the ureter is, uterine artery is ligated where it crosses the ureter, and in radical hysterectomy, it's in its origin from the superior vesical artery or the internal iliac artery. And the cardinal ligament is in the radical hysterectomy is cut in the more lateral and towards the pelvic side wall. And in the radical hysterectomy, the pubocervical uterosacral ligament is resected more to the rectum, and in the modified radical hysterectomy, it is resected more to the cervix. And in case of in the vaginal difference, in the modified radical hysterectomy, we resected vagina in upper 1 to 2 centimeter, and radical hysterectomy is 2 to 3 centimeter of the vagina. We are now more thinking about the nerve sparing surgery, because to avoid the bowel, bladder, and sexual dysfunction, and to avoid to do this, we have to think about and cautiously do the surgery during the dissection of the uterosacral ligament and the parametrium, because the inferior epigastric nerve and the pelvic splenic nerves to be preserved, and these are located in the vesico-vaginal ligament and the uterosacral ligament. Here's some figure showing that is the division of the uterosacral ligament, that a hypogastric nerve, and this is the inferior epigastric nerve located in the vesico-vaginal ligament, and for the bladder branch, that is the rectovaginal ligament, and the division of the paracolpium is to be think about, and during the surgery is to be preserved. Sentinel lymph node biopsy has been widely studied and clinically used for many types of cancer. In early stage cervical cancer, it is practiced to avoid the morbidity like lymphadenoma. Techniques are blue dye and gamma probe with radioactive isotope, which can be done via the laparoscopy or laparotomy. Recently, injection of the indocyanine green into the cervix as a tracer and detected by the near-infrared fluorescence imaging in retroperitoneum. It has increased the overall and bilateral sentinel lymph node detection. In the NCCN guideline 2021, there is clearly recommendation for the fertility sparing surgery, where we see that in the stage 1A1 with no LVSI, cone biopsy with negative margin is recommended. And in stage 1A1 with LVSI and stage 1A2, radical trachelectomy with pelvic lymphadenectomy can be recommended, and consider the sentinel lymph node mapping. In stage 1B1 and selected cases of stage 1B2, radical trachelectomy with pelvic lymphadenectomy plus minus para-aortic lymphadenectomy can be done considering the sentinel lymph node mapping. So my take-home message is the preoperative diagnosis, assessment, and preparation of a patient of cervical carcinoma with proper staging is very much important for a good surgical outcome. And to achieve the single modality of treatment, a teamwork is very much needed between the gynecologist, gyne-oncologist, pathologist, radiologist, and radiation oncologist. Thank you all for patience hearing, and I very much thankful to the Oncology Club to giving me the opportunity to present this case. Thank you.
Thank you, Dr. Lutfa, for your nice presentation. The aim of the another aim of the Oncology Club is to manpower development, and accordingly, we arrange this lecture series. At first, the junior, our resident or our junior colleague, we arrange that they will present, and after that, our overseas faculties, they will present. And accordingly, we are very much grateful to all our faculties. That's because after the presentations of the junior colleague, they never denied to present. So we are very much grateful again to you all. And now I request our faculty, Dr. Shailosri Surappa. She is gyne-oncology specialist accredited UK and professor and consultant gynecologic oncologist, Tata Memorial Center, Mumbai. From Royal College of Obstetrician and Gynecologist, accredited gyne-oncologist of British Society of Gyne-Oncology, and she has more than 100 presentations in international meetings and peer-reviewed publications in high-impact journal and she is the first author of 2 Cochrane review in gynae-oncology and co-author of the 2 ongoing Cochrane reviews. So I request our faculty, the renowned faculty, Dr. Professor Shoilosri. Shoilosri, ma'am, please.
Thank you very much, Sahana. Thank you. Nice, lovely to see your face again. And thanks everyone for the kind invitation. Can you hear me?
Yes.
Thank you very much. That was a nice presentation. What's her name? Luffy?
Dr.
Lufa.
Lutfa.
Okay, yeah. A nice presentation. Very pleasant faces you have, all of you. Two things. I will go back. I've recorded my presentation so that there is no hiccups with regards to time. What I would like, because I've come in here as almost a teacher to some of the junior residents, and we do that every time in Tata as well, lots of residents. So lovely presentation. Few things for improvement. Obviously, the whole thing is to improve the education system of all of us. When you present things, there are all obviously things which are published in textbooks and protocols. We all read that, we all know that. I would want our junior residents who are upcoming.
এটা অঙ্কোলজি ক্লাব থেকে খুব সুন্দর প্রেজেন্টেশন হয়।
Can you hear me?
এদেরকে মিউট করে দেন।
হ্যাঁ, ঠিক। So just do a pattern recognition. What happens is I've put up a few slides. Just do a pattern recognition of what is happening, what has happened in terms of studies, and what we are going to expect in the next 5-10 years. So an overall view you need to give. And then I would rather advise people to read more of publications and trials than textbooks. We are very used to in Indian subcontinent reading big fat textbooks for a very long time during our post-graduation MBBS days. I would suggest all of you residents and upcoming young oncologists, please start reading trials, because you get different type of knowledge and your brain starts thinking differently. That's my one advice I would give my residents every day, and I would give you guys as well. So, and also the third thing I would emphasize is problem-based learning rather than protocolized learning, because retention of knowledge is much higher. If I put up 3 cases and then come back to the guidelines, then people remember better. So the whole point of the system is to retain knowledge, and knowledge is retained when you poke people rather than when you make them listen to them. So this is my little tiny advice, but very good presentation. Everything was covered in the presentation. So actually I'm going to repeat a few things. And then should I share the screen, Shahana?
Yes.
Okay. Video final presentation. It's the same presentation which she said, a little bit of pattern recognition and trials have put up so that all of you go back and look at all the trials and see in each trial there's something which they're trying to address, but so most of the trials in a particular slide are trying to answer the same question. So that's the challenge for residents to look in and check. This is my hi, good evening. Next slide. Okay, sorry. It's not starting. Can you hear it? No. These are standard society guidelines, as you all know. Conservative surgery should be advocated to preserve fertility in young women for all stages of operable cervical cancer. Either we can do a cone biopsy or a trachelectomy depending upon the stage of the disease.
You cannot see the screen.
You can't see the screen?
No, your screen is not sharing.
It says it's sharing. These are some of the general rules of good practice. Just give me a minute. However, your screen sharing, it says.
Ma'am, can I take a moment? Ma'am, first of all, you have to on the video and then you have to share your screen.
Yeah, okay. Let me on the video share, new share. Okay.
Velusri, please stop sharing. Open the video, then go for sharing screen.
Stop sharing and share.
Open the video, then go for screen share.
I'll come back in a minute. So let me open the video. Yeah, I've opened the video and just give it. Where is the screen sharing?
Now share screen.
I'll just, okay. Um,
No, you first stop share, open the video, play it in your laptop, then share the screen.
I've done that, but it goes back to the same. It's here. It's open. Okay.
Play it.
Okay.
Play your video, recorded video in your. Start playing and then share the screen.
Okay. I play the video now.
No.
Hi, good evening. Can you hear me? Nice to see.
Yes.
Then
Can you
now
see the
share
video?
the screen.
But the screen is not sharing.
Still not sharing?
I've put up a
No.
few.
Sorry about that.
These are
What's wrong? Okay, give me a minute. Okay. Now I have a slideshow. Sorry. I'll put this up first. Okay. Now I'll go back.
These are standard society guidelines.
You can hear me, but you can't see me. Correct?
Or you can upload it to our Google Drive. We can play for you.
No, I'll play. Yeah, I'll do it in a minute. It should be okay. Yesterday also we had the same problem. Okay, I've stopped sharing. I'm thinking. Okay, share screen now. Yeah, and only when I say share screen. Let me see. Yeah, can you see now?
No.
You can't see my screen at all. Can you see my screen now?
No.
Sharna, share the Google Drive. Let her upload. We play.
Can you see this?
Yeah. Now,
Can you
Yes,
see the
yes.
screen now?
Yes.
Okay, you can see I see the slides now.
Yes.
Okay. Let me get the slideshow. 1 minute. Okay.
These are standard
you hear me
society
now?
guidelines, as you all know. Conservative surgery
Can you hear me now?
yes, please continue.
Yeah, thank you very much.
should be advocated to preserve fertility in young women for all stages of operable cervical cancer. Either we can do a cone biopsy or a trachelectomy.
Okay, let's talk now. Okay.
These are some of the general rules of good practice. However, these points, the reason I put up these points is they get discussed. We discuss this a lot in many meetings because of the type of healthcare we work in. Sometimes there are no frozen section facilities available for us to know the lymph node status when we are operating on these women. And also, frozen section might not be that sensitive for us to make a decision based on just frozen section alone. With regards to Settles criteria, many people think it's probably an over treatment for these women. However, I would suggest or advise to follow your institution guidelines, or if you don't agree with it, it's preferable that you join a trial or you conduct a trial yourself. The next few slides will discuss briefly some landmark trials which residents need to know that change evidence for surgery in cervical cancer. The famous Landoni trial in 1997 and its update in 2017 you must have all read, which made radical surgery the standard of care in early cervical cancer. Note the 5-year survival of open Vardhams was 83% in the trial, as opposed to 95% in the LAC trial published recently. And MIS is 85% in the recent LAC trial. So the MIS is almost equivalent to the Landoni trial results of open surgery, which made open surgery the standard of practice. This is a point to ponder. Have we reached the highest skills for open surgery in the last 2 to 3 decades? Or are we operating on small disease, which makes the survival much better? And also, will we ever reach the same skill levels for MIS? Hopefully, the trials will answer in future.
Now, the most controversial trial of the decade is a LAC trial. I feel the storm will only settle in the next. So these are some of the trials and studies which showed MIS is not safe in cervical cancer. You've heard this in many meetings. One good RCT LAC trial and one SEER analysis, and many retrospective studies after the LAC trial was published showed inferior DFS and OS. It was shocking at that time, but that's true. Open surgery touching an average 95% DFS and MIS is hovering between 85 to 90%, making hazards ratio worse for MIS surgery cancer. After that, there was flooding of retrospective real-world data and literature, and this meta-analysis in JAMA Oncology 2020 showed an open surgery was much better than MIS surgery. A few studies were bordering on equivalent survival or non-inferior survival. To our relief, then came even bigger studies, some retrospective and some from population-based registries, confirming the beliefs of some MIS surgeons that what we were doing for such a long time is not all that bad. So uterine manipulated exposure of the exophytic growth during colpotomy might have spread the cells into high pressure abdominal cavities, what Soccer said. It makes sense to me and also to many MIS surgeons. The real world data for 3 countries, Scandinavian and Dutch, showed no difference in OS and DFS from the population-based registries, which are considered the best registries. Then we had the Oriental study, a multi-center study, which came up recently, emphasizing non-inferiority of MIS in less than 2 centimeter tumor. Again, confirming the belief that the large tribal growth in the cervix is probably the cause of all the problems in MIS. There are no RCTs for trachelectomy, only observational studies which have shown no difference in overall survival. We have to be careful here because we are still operating on, generally we operate on less than 2 centimeter tumors in young women who are suitable for trachelectomy. So is it the disease size which is making no difference in overall survival is a question which might be answered or might not be answered. These are the sentinel node areas for cervical cancer. As you all know, it's obturator and iliac nodes commonly below the pelvic rim, which is the cause of the problem in cervical cancer. These are some of validation studies, Centicol 1, 2, 3, and Centex studies. Basically, the take-home message is frozen section is inaccurate for SNLB. Identification of bilateral sentinel nodes is very important to get the negative predictive value to near 100%. And lymph nodes in cervix are difficult to salvage, so we have to be careful with NPV in cervix. So the surgeons, MIS surgeons have decided to prove that MIS cervix needs to be looked at again because one trial means something, but it's not the end all trial. So these are the ongoing RCTs. So hopefully we'll get the results in next 4, 5, 6, 7 years time. And depending on the results of all these trials, we'll come to an equilibrium with the MIS in cervical. Now, these trials are minimizing radicality in surgical treatment in cervical cancer. Some of them are ongoing, and this is for less than 2 centimeter tumors. And do we really need to do radical surgery for these tumors is a point they've been asking. So again, we do not know whether if we apply MIS in this, can we apply MIS again in this setting is a question which is still unanswered. Now, there are certain other indications in locally advanced cervical cancers. The definitive treatment for cervical cancer, locally advanced cervical cancer is CTRT. But in certain situations, there is a scope for staging laparoscopy or MIS for looking at para-aortic nodes which are not enlarged on CT scans or PET scans, and to restage the disease and also surgically stage the disease and alter radiation treatment to improve survival. The second indication, which last decade was controversial, was neoadjuvant chemotherapy followed by surgery. Now it's not recommended, even though it's appearing as grade C evidence in ESMO guidelines. It will be grade A when they change the version because of the our own study, TMH study by Dr. Gupta et al. And the EVO-RTC study, which are getting published. The other indications are lateral extended dissections. You need to get skilled in this particular surgery. These are surgeries where the patient has nothing else. We have nothing else to offer these patients. So we are doing these surgeries and hopefully we'll give them some DFS and overall survival without compromising on too much quality of life. Exenterative surgeries come under the same category. Post CTRT or pre CTRT. Could you hear that?
Yes, your slide share is ended.
Yes, slide share is ended. That was my small presentation because I thought there will be an overlap with the students' presentation. I've got video presentations now, and I've got some slides. I think we'll go to video presentation and we continue talking in terms of what to do, what not to do. That will be much more interesting for surgeons than guidelines and thing. So this is what I was trying to say. For residents, please read trials and see what is the future. That way you'll know. You have to learn the skills. There is no second compromise in not learning the skills, but also putting knowledge in the right place and also learning the skills makes the oncology department much stronger. So now I'll share screen. I need to open the video and any questions on that from the group presidents? I've not seen the chat box. So the video presentation, I'm going to show you pelvic lymphadenectomies, how to approach the lateral pelvic wall, how to approach the veins, to look at the ureters, the tunnel, the bladder pillar, and the nerve spaces, and some transposition video, laparoscopic transposition video I have. I've got one bladder repair as well, who had a big fistula following hysterectomy and was referred to us. Let me see if I can share the video. And show. Okay. Now let me start the video and then okay, I need to do the slide share now. I'm starting the video. Dr. Sahana, can you see my slide pelvic lymphadenectomy? No? Not yet? Can you hear me?
Yes.
Where is your screen share? Can you do the screen share from your side? No, okay. Open it. Can't see your screen share some reason. Big file. So, can you do the screen share from your side? No, isn't it? It will be difficult.
Yes. If you email me, then we can do this from this side.
Is it minimal video?
Help.
Yeah, okay, I'll do that. I got it. Screen share. Can you see this pelvic lymphadenectomy?
Yes, yes.
Can you see the slide screen?
Yes.
Yeah, brilliant. Let me make it bigger. Okay, there's no voice recording on this. Can you hear my voice now?
Yes.
I'll talk through the video. So most of these are minimal access methods. It's easier for us to record minimal access methods. It's also important that you see the anatomy bigger and you learn it, and you can use the same anatomy for open surgery. So this is a pelvic lymphadenectomy video. Let me see if it starts. Can you see this?
Yes. Yes.
So we are going into the lateral pelvic wall. There are experts who are doing all this regularly. I'm talking for the residents as it's a teaching program. So what I tell my residents is go and find the psoas first and then move, or go and find the white pubic bone, which is the right or the left pubic rami. You can see that white bone there, to go into the obturator fossa. So now this is the psoas major muscle, and we are moving along psoas major and moving medially. No need to take out too many lymph nodes external to the psoas major. That's the white bone, pubic rami. I'm going into the obturator fossa here after clearing the external iliac vessels along psoas. Now, what I tell my residents to find the obturator, now you go to the inferior border of the pubic rami and keep moving, keep moving, keep moving, and you'll find the obturator now. If you try to find the obturator nerve in the paravesical fossa, you generally tend to go too low because that space is avascular and it feels nice. Now, once I've looked at the obturator nerve there, you can go behind the psoas major and remove all the tissue. This is very helpful, the lumbosacral approach in fat patients. In thin patients, it doesn't matter. You do the regular methodology. So you have to be careful with the psoas perforators when you're doing this lumbosacral approach of pushing the vessels. So once you push the lymphatic tissue here and here, you separate the external iliac vessels from the external iliac artery. You can see the obturator nerve. You see the inferior border of this white bone, and that is exactly where you need to find. Don't separate it here because you'll see the obturator vein here. Look at that. That's obturator. So try to separate the obturator nerve here first and then move along. When you come closer to the bifurcation of the vein, or the confluence of the external and internal iliac vein, be careful because you will not see the internal iliac vein and you might injure. There's no need to go below the obturator fossa in most of the cases for pelvic lymphadenectomy unless you have a node enlarged or you're going to do a lateral extended resection for post-CTRT cervical cancer recurrence. Small parametrial disease still left behind, you can go and do a lateral pelvic resection. You see two muscles here. One is the psoas major and one is the obturator internus in the obturator fossa. This is a nice cost-effective method I use. I take a 8.5 gloves, thumb of it, and I put all my nodes into this and keep it there. And once I do the hysterectomy, I push it out of the vagina. Or you can take it out of the suprapubic port. Only thing is it's too big to come out of the suprapubic port, so I remove the specimen and then put the port back. So once you've done the obturator fossa and the external iliac vessels, you don't need to do this procedure, but you need to know the anatomy here. That's why I'm showing this. This is below the obturator fossa disease, which rarely comes in standard stage 1 cervical cancer. It is basically recurrent disease. We do that. I'm going below the obturator fossa and I ligated the obturator vein there. Now, this is the external iliac vein and the internal iliac vein confluence. Very careful you have to be because the internal iliac vein dips down. It doesn't come straight, it dips down. Branches of the internal iliac artery going towards the obturator fossa. I'm ligating. You can see the obturator nerve there. Obturator artery I've ligated. We generally see the vein when we do the standard pelvic lymphadenectomy, but when you go below the obturator nerve trying to do the lateral extended resection or layers, you see all these tissues. So you remove these tissues. I'm showing this video only for anatomy. You don't need to do this often. So if you see the obturator nerve and you see a vessel coming towards the obturator internus muscle. This vessel is a branch of internal iliac artery going towards the obturator fossa, and it divides into pudendal and inferior gluteal vessels. Okay, this one. So above here, your obliterated is going. This is the internal pudendal artery, which is going into the greater sciatic nerve. So you ligate, clip, or use ligoshaw, but generally we clip these vessels because it bleeds in the it bleeds in that pelvis and makes the laparoscope go pink and red. That's the inferior vesicle. So if you go back now and read the branches of the internal iliac artery, we all know the superior vesicle and uterine artery, and we have seen the obturator vein most of the times in our day-to-day practice. We need to know a little more anatomy than generally we need, so that we know where not to go and what not to injure. So once we have done this, if you follow the pudendal artery which I showed you, it takes you to the lumbosacral trunk. So when we say lumbosacral approach of coming from above, that is what we mean, because we're trying to enter the lumbosacral region, which is basically L5, S1, S2, S3, which becomes the sciatic nerve later on. So notes removed. Just a minute. I need to stop this. Look at this. This is the pudendal vessels. This is the lumbosacral trunk. This is the sciatic foramen. So now, if you track the pudendal vessels, it starts here, it goes as inferior gluteal there, and the pudendal goes here. So there's a big vessel here which divides later, which I showed you before. And if you track that, you come to the lumbosacral trunk. The next clip is on that. Can you hear me?
Yes.
Thank you. So I'm coming to, so this is the picture I'm showing. This is the internal iliac artery. This is the obliterated hypogastric, which we all know. Now, more obturator artery has come there, and if you see this vessel which I showed you, which is dissecting, divides into internal pudendal and inferior gluteal. This is the smaller one is the inferior gluteal, the bigger one is the pudendal. If you track this, sorry, if you track this artery alongside the lateral pelvic wall towards the obturator, below the obturator fossa, if you track this, just underneath that is the lumbosacral trunk. So this is the dissection which you need to learn if you're going to do a lateral extended resection. Most of the times, obturator internus muscle is not involved, but the indications are becoming wider and wider if people have started removing the obturator internus and going up till the bone for recurrent cervical cancers. But most of the times, a small parametrial involvement is there, nothing else is going on, and we can go as long as we go up here, conserve all these structures, clip all the veins possible, other than the external iliac vein and other than the obturator nerve, you can clip everything here, and you can take out all the tissues in a lateral extended resection of the recurrent cervix. So is it moving? Okay, now what am I showing? Now, this is hysterectomies. Suppose you are doing a 1A1 or a A2 simple hysterectomy for cervical cancer, or you're doing an endometrial cancer. What I find my residents or beginners do is, when they cut the vagina, they would have done the uterine artery here. It's a simple hysterectomy. They would have done the uterine artery here, and they would do a little bit of cutting here, and then suddenly they start cutting the vagina. If you cut the vagina too early without doing the parametria, or without doing the Macken rod, in an open hysterectomy, we generally do a Macken rod and a uterosacral and then cut the vagina. Somehow in radical hysterectomy, you do the uterine artery and you're trying to do something here and you've not cleared the lateral fornix, then you struggle when you cut the vagina. When you do the colpotomy minimal access, you start struggling. So that's what I'm trying to show, a small clip on hysterectomy, which everybody knows what they're doing. So don't cut the vagina too quickly, clean up. Now look at this. So if I've cleaned up the whole this is the uterus, uterosacral and everything all cut nicely, simple hysterectomy. I put the McCartney here, which is a tube, basically a plastic tube, which I do not know what you guys use, but this is McCartney I use. So you can see you can feel the McCartney here. The bottom person is pushing the McCartney here. And then when I make a cut, the cut becomes easier. It becomes nicer, and you will not lose the gas trying to do too much surgery at this point. And another mistake most beginners do is they start cutting the anterior vagina first because it's nice and thin, it's easier, and you feel good while you're trying to cut the anterior vagina. You feel good because it's an easy procedure. But what happens then is when you cut the anterior vagina here, the uterus falls back. Once the uterus falls back, it's a nightmare because you start losing the gas, the cervix goes here and there, you're worried where there is a spill, and the assistant is now doesn't know what to do. So what I generally suggest for all beginners or intermediate level minimal access surgeons is start the cut here, cut, go posterior, cut, go as far, go there, and then cut the vagina, whichever way you want. That will take only 2 to 5 minutes. Otherwise, it's half an hour lost. So this is a trick again for beginners, I would say. So see how thin the lateral fornix I've made. So you make the lateral fornix thin beforehand, before cutting the vagina, and then you keep moving the uterus in front and cut the back, basically. So that way the cervix remains inside the inside the back artery. The chances of spill are less. Now I go and cut the intravagina, which takes more or less than a minute, and it's easier. Keep the bladder away while you're doing this, and few movements. Don't pull, push, prod the cervix as a uterus. Don't pull it up in the air and then try to put it back. Very minimal movements, and then push it out of the vagina. And I generally do a figure of 8 stitch. In open surgeries, I don't close the vagina. I go put a runaround stitch. I don't put a drain for anybody, pelvic, paratic, radical, nobody. Except for peritonectomies and cytoreductive surgeries, I don't put drains. And groin nodes, I put drains, but not anybody. The para-aortic lymphadenectomy, same principle. If in CS cervix, generally we don't do para-aortic lymphadenectomies, but if you have to stage cervix stage 2B or 3B, if you want to, if there is an indication, there are phase 2 studies going on. If you have to do the lower para-aortic nodes below the IMA, you can use the same trick. And in endometrium, this particular trick is very helpful. Let me show you the para-aortic lymph nodes. So always you start from this is a robotic para-aortic lymphadenectomy. Start from the pelvic side first because we are used to pelvis. So I know where I am when I start from the pelvis and move upwards in minimal access. In open surgery, it doesn't matter because the dexterity, you don't need so much dexterity in open surgery. So you walk along the vessels, be very slow. No need to rush a surgery because once a tiny vessel starts bleeding, it will mess up your view, and it will mess up all this white color. It becomes red, and after that we're struggling. So we're coming to the common idea. Can you hear me? Sorry, there's disturbance. So the same skill you use in any lymphadenectomy, whether you're doing head and neck lymphadenectomy or pelvic lymphadenectomy or groin node dissection, it is open, close, open, close. Take the tissues, buzz them, not because there are bleeders there are lymphatics there, which will make which will get cover, which will get clogged if you clip them or if you buzz them. If you just tear them, you will end up with too much lymphedema in those. So it's always preferable to clip everything. So I'm coming to the IMA here, lower para-aortic. Moving up the vena cava. Sorry, this is the left common iliac vein. We are at the bifurcation of the aorta. So for advanced cervical cancers, in terms of 2B and 3B, for staging, surgical staging, there is an indication, but it needs to be done within trials or at least as an audit to see if it makes a difference to the patient. If you look at the LeBlanc series, if these nodes in cervical cancer, non-enlarged on CT scan and PET scan, but they are microscopically involved. If the node is less than 5 millimeter involved, then if I extend the radiation to those nodes, the survival of these 5 nodes is similar to having node negative. Being node negative and having less than 5 node, if we remove them and give them radiotherapy, the survival is the same. However, if it is more than 5 that means it's almost covering the whole lymph node, not enlarged, but it is still involved, then the survival drops. We have got an RCT which is going on, which will tell us whether we genuinely need to do para-aortic lymphadenectomy in cervical cancers, whether it's going to help or not. It's better to do a futility analysis to see at least if there are 15% of the lymph nodes involved in this area, then I think it's worth doing. If it's anything less than 10%, I think we have, it's too much a procedure. And it has to be done minimal access because the patient has to go for definitive CPR. So between generally most of the gynecological cancers, common sense dictates that right gonadal veins or vessels get arise from the aorta, and at that level there is a small chance nodes could be involved. But the only problem here in this area, all of you know, is the duodenum and the renal vessels. So don't do things which are not indicated because we might complicate patients unnecessarily without any use. These were in these videos I'm showing are on endometrial cancer patients who had high grade serous tumors and more than 50% invasions. And these are the videos on that rather than cervical cancer. I clip all the vessels close to the duodenum so that the chyle doesn't leak and make my life miserable or patient's life miserable rather in post-operative period. So that's the robotic para-aortic lymphadenectomy. So I'm doing laparoscopic one as well. It's the same technique. Keep going above the vessels and doing. Your assistant needs to be good and you tunnel it along and take out all the lymphatics in and around the aorta. Intra-aortic cable, you be careful because you might injure the nerves here. IMA. Most of the cervical cancers for surgical staging for local advanced cancers, the indication is below the IMA now. Phase 2 studies did between IMA from renal hilum, but they did not find any nodes in cervical cancer above the IMA. So you can go up till the, this is what am I showing here? Okay, the same bone. Remember, this is the accessory obturator vein. This is the pubic rami. I'm going into the paravesical space, a very nice avascular space. But remember, if you go too deep down, you will hit the levator rami there. So if you go here, you will see the white bone, the pubic rami. It's very nice and glistening. You will see only one vein which you can injure here. That is the accessory obturator vein. It connects the obturator vein, external iliac vein, and the obturator vein. So it will bleed from there. It will bleed from here. So both are dangerous. Now, if it bleeds from here, it's very difficult to suture in a laparoscopic surgery underneath of the external iliac vein. So if you see a vein and if there's a node here, I would just clip them or ligosure, and then remove the nodes so that they don't bleed from here and here. So I'm going into the paravesical space here. It's a beautiful space. This is how you approach the obturator nerve, somewhere here, but you should know where exactly it comes basically. Now this is a part of a radical hysterectomy series I'm doing, and that's the infundibulum we have cut and clamped, and this is external iliac vessels. Looking at the ureter, tracking the ureter. Now this is what has been taught for many years, how to track the ureter. Go above the ureter, don't go to the sides, it will bleed, which is understandably correct because all the vessels go, the sides are underneath the ureter, and just if you track the ureter above, the first vessel which crosses the ureter is the uterine artery. That's how you recognize uterine artery. In open surgery, you can pull across, but sometimes when you're learning minimal access surgery, um, you might get confused with the superior vesicle and start tracking that towards the bladder. So you have to be careful. This is, I'm ligating the uterine artery at the origin. This one is obliterated and you can see a small vessel going, that is a superior vesicle. So water under the bridge, all of you have heard that terminology of ureter below and uterine artery above. I'm coming to the Okabayashi space. Um, this is the uterine vein space, basically. Let me see. Okay. This is the Okabayashi space. Now, in radical hysterectomies, generally we are initially, as beginners, we are taught paravesical and pararectal spaces. These two spaces are divided. Their anterior is paravesical, posterior is pararectal. And what crosses those two spaces is the uterine artery complex, the superficial uterine vein and the uterine artery. That is standard teaching. Now, if you come to nerve sparing hysterectomies, you need to know two more spaces. One is the Okabayashi space, which is posterior, and one is the Yabuki space, which is anterior. Now, the division, it's the same space actually. It is along the uterosacral going ahead below the ureter. So these two spaces are connected, are divided by the deep uterine vein. So once you clip the deep uterine vein, you will, these two spaces become the same, and these are the nerve spaces. The parasympathetic and sympathetic. Parasympathetic goes longitudinal along the rectum and comes into the space from like this, and parasympathetic comes like this and forms the inferior hypogastric plexus, just like the photo picture which the doctor showed. So I'm going, see, this is the ureter, which is lateralized. Now I am between the ureter and the uterosacral, and I'm trying to push all the white looking things here, keep the uterosacral to the specimen side and push everything which looks white and long onto that side. Those are all the nerves. There is a lot of tiny hair-like nerves which come up here because we are approaching the hypogastric plexus. Hypogastric plexus is not one nice yellow looking thing which we see in pictures. It is confusing sometimes. So what you need to do here is just push all the tissue, keep only the uterosacral and push everything. I'm coming to the deep uterine vein. Look at this. This is the deep uterine vein. This is the one which bleeds in all your Vardham surgery. This is the ureter here. This is the ureter here, and this is the deep uterine vein. This one. And here you see the vesicle vessels. There are two vesicle vessels, sometimes three. One running longitudinal, one running parallel. Both of them get connected to the uterine vein. So if the uterine vein bleeds, everything starts bleeding here. If you, all of you who have done Vardhams, many of your Vardhams will bleed here, somewhere here in this area. Till the uterine artery ligation, your Vardhams is beautiful. After that, God knows what happens. So you start putting big hygienic clamps here if you are doing an open surgery. And by doing that, you will kill all the nerves because all these will bleed. Just underneath this deep uterine vein is the parasympathetic chain coming from here. S1, S2, S3, S4 coming all the way and joining here just below the deep uterine vein. So what we do is we don't have to go around looking for the parasympathetic, just push down all the tissue below the deep uterine vein and just clip the uterine vein. Once you do that, the parasympathetic is saved, the sympathetic is saved in the Okabayashi space. You move this complex towards your side and you'll have one nerve, small thin nerves which are very hair-like. You can see better in robotics. Sometimes in laparoscopy, open surgery, it's very difficult unless you wear a loop to operate. One or few of these white strands go towards the bladder. One or few strands go towards the uterus. These are the uterine branches of the hypogastric. There will be the bladder branches of the hypogastric. So the rule of thumb is you can cut anything you want in here for nerve sparing. Your C1, Morlow's C1, so radical hysterectomy, and you leave everybody there so that the patient will not have atonia or doesn't end up having a self-catheterization for a long time. So this is one space. Please go back and read all the journals and all the videos you see for nerve sparing and you realize what it is. So uterine lateralization of the ureter is one of the most important steps of radical hysterectomy, but if you carefully look, more than lateralization is easy, but to get all these vessels is difficult. They bleed. Open surgery, what we generally used to do was this is the same picture lady showed. Generally, what we used to do in open surgery was to put a nice huge clamp in the uterosicle low down up till the vagina, and we used to get the whole of the deep uterine vein. And but with that big clamp, we used to get the nerves as well, generally the sympathetic nerve. And when I put the clamp in the Meccan rod, I will get the parasympathetic. So we were getting both the nerves because we were not separating them. Over a period of time, many people showed their videos, especially the Japanese, and we started looking into it. And also the magnification which came up with laparoscopy and robotic made it much easier. Otherwise, people used to say there's a nerve there, and I never saw it for first few years of my training. I never saw a nerve, and I used to struggle. Where is the nerve? Where is the nerve? I was thinking the nerve will be like this. It's not like that. It's very thin. Now this is a robotic video, much better. Now obturator nerve, obturator vein, this is a standard pelvic lymphadenectomy I've done. What I'm trying to do is the internal iliac artery here, which is this thing, and the uterine artery is coming here, and the ureter is here. So we'll look at this area is very important in your radical hysterectomy and pelvic lymphadenectomy, because you try to do anything in this area, there is posterior branch going along superior gluteal vessels going into the obturator internus area, which I showed later, the pudendal deep down, and the lumbosacral trunk is somewhere there. Can you see my arrows? Can you see the arrows?
Yes,
Hello?
ma'am.
Yeah, thank you. Can you see this mouse I'm showing so that it's helpful to the students?
Yes, ma'am. The mouse is visible.
Yeah, thank you very much. So this area, be careful. You pull the lymphatics up in the air, up this way. Don't pull it this way, because it'll if you pull it too much, some of this starts bleeding. This is a video of the internal iliac artery. Now, this is important. Pararectal space, which we have been taught. Be careful of the pararectal space because it's a small space. Only when you make it, it's a potential space. So the ureter is here. Now this is the superficial uterine vein. This is a uterine artery. We know that. So uterine artery we clip here. When we clip here in Vardhams, we try to pull the uterine artery towards our side, but the uterine vein doesn't join here. It joins here. So sometimes this starts bleeding. So what I suggest is you clip there, but you make a clip a half a centimeter further as well, because that way you would have got the superficial uterine vein. Okay. Is it playing? Sorry. Sorry. Went off somewhere. This was the video. Sorry, that I went backwards. Bear with me. That's okay. Come on. This is the branch which I was showing. In the under the obturator internus muscle. That was. Now this is the video which I was trying to show you guys. Let's see. Okay. The minute a Newton artery is given, your obturator becomes so thin, even the assistant can pull and prod. Now, this is again very important. This is internal iliac vein. Internal iliac vein doesn't come like a rod. It comes like an amoeba. It is not like the external iliac vein. It is got this big. It is this big. It's like a well. Sometimes there are two of them. Sometimes there's one, and too many veins go there. Sometimes you can't name them. There are obturator veins. Sometimes one, sometimes two. So this is internal iliac vein and its tributaries. So look at this. This is the deep uterine vein coming up. I showed you the superficial before. This is the deep uterine vein coming up. Sorry. This is the deep uterine vein coming up, and underneath the deep uterine vein will be the parasympathetic chain. This area is parasympathetic. I'm showing that now. Yes. Deep uterine vein, parasympathetic nerve, all coming from the lateral pelvic wall. Okay. I'm playing it now. So now I'm going into the left uterosacral ligament. the video I showed you, I was coming from lateral to medial side. Now I'm going, you can do it either way, but general rule of thumb is come from lateral to medial side, come from the lateral pelvic wall towards the uterus. Here, and this is a demonstration I was trying to do for my residents. This you can go from medial to lateral side, find the same vessels from this side to that side. So I'm doing the uterosacral here. Be careful, you might enter the uterine vein and make a hematoma there. So we are trying to see see that ureter moving there. This is the ureter moving there, and on top of it is the uterine artery. So I've come from this side now instead of that side. That's the standard side. So this is the ureteric tunnel, ureter going there, Okabayashi space, and uterosacral. So I'm separating the uterine artery. Dr. Sahana, tell me if I'm overshooting the time. I get involved in teaching, and after that it goes on and on.
Oh,
So that is the bladder pillar. Look at that. This is the ureter going. I've gone past the, let me stop this for a minute, otherwise it will move. Uterine vessels. I wanted you to see this because this is very important space. I need to stop it somewhere. When you go past the uterine vessels is when you see the Yabuki space. Behind lateral is the Kobayashi, just lateral to the uterosacral. When you go in front, see this, uterine artery is here, bladder pillar is here, and ureter is going there. This will be the Yakubi space. So this Okabayashi space and Yakubi space will become continuous here once you have done the deep uterine vein. Now this is a video of colpotomy for cervical cancer, but this will help you do trachelectomy. All of you have done vaginal hysterectomy, is no big deal. So every gynecologist knows how to do this. Instead of putting this incision here, which we do for vaginal, you go up, take as much vagina as you want, and move it towards the cervix. Be careful not to go towards the bladder, but move the flap of the vagina down. So this is vaginal colpotomy. This is the same trick which we use for radical trachelectomies. And you can take as much vagina as you want. And what I'm trying to do here is to find the internal os. This is a demonstration of how a trachelectomy should be done, but this is not a trachelectomy video. This is a radical hysterectomy colpotomy video. I've done all the radical hysterectomy minimal access, and I've come down, and then I do this. Basically, I push all the vaginal folds onto the cervix, push the bladder up, take as much as vagina as you want. 1.5 to 1 centimeter is more than enough. You don't need to take 2.5 centimeters of vagina in young women. And once I do the sound, I know where the internal os is, and I'm giving an instruction that is the internal os, and that's where the cut should be. That's where the cut should be. It's an easy surgery. All of you can do it. You need to see it once. So I close all that, and this is not a trachelectomy I'm doing. You cut here, and once you cut here, then you put your vaginal cervical stitches with sutures, knots pointing outside, not inside the endocervical canal, to reduce stenosis in trachelectomy. Now I enter the pouch of Douglas, and I enter the bladder UV fold peritoneum, and I remove the specimen without exposing the cervical disease into the peritoneal cavity in MIS surgery. This is what I've been doing since 2014-15, and then suture the vagina. So it's this is how even a radical trachelectomy is done, except we cut it here basically. This is the specimen. You can get as much vagina as you want. We don't need to see groin node. What I want to show you is not groin node. I wanted to show laparoscopic ovarian transposition for both cervical cancers, non-cervical cancers, young women who need radiotherapy. When you are doing open surgery or laparoscopic surgery for young women with cervical cancer, please put their ovaries up. You might think she might not need radiotherapy, but we do not know. Once some of them do end up needing radiotherapy now or sometime later. So it's better the ovaries are up. Anyway, we have removed the uterus, so there's no point keeping the adnexa closer. So disconnect the fallopian tube and the ovaries from You can remove the fallopian tube or you can keep the fallopian tube. I generally tend to keep the fallopian tube because the vascularity is, there is vascularity between the fallopian tube and the ovaries. All I'm trying to do is, this is the infundibulopelvic ligament. Don't be too close to the infundibular, go farther away, because if there is a hematoma which sets in here, then you will clamp the infundibular without your knowledge to reduce the bleeding. So moving the adnexa completely up along with its pedicle. So disconnected it from the, what I'm holding is not the fallopian tube, I'm holding the ovarian ligament. Try to get a good chunk of ovarian ligament at the, when you cut the ovarian ligament at the uterine level. So move the adnexa along with its blood supply above the pelvic brim. Even the infundibular should go above the pelvic brim so that radiation will not affect the vascularity of the pedicle. Move up slowly. This is a fiddly surgery. You can see you're coming up to the ureter. This is the ureter here at the brim, crossing over, and this is the infundibular pillar. Now this is the only area. This is the only area which is very close between the infundibular and the ureter. It's very close. You can use a monopolar here. I generally tend to use ligashore because residents can operate with ligashore, and I'm not worried with monopolar. I'm worried where they'll touch the bowel or something. So I make them use ligashore, but you can use anything you want. It doesn't matter. So I'm going past the ureter and moving the infundibular up in the air. See that? So I want the whole complex to be above where the ureter crosses the pelvic brim from lateral to medial side. Move up and I'll just post reverse forward. Beauty of LOT is ovarian vessels come from aorta. That's why we can do what we can do. You try to keep it 2 to 3 centimeters above the umbilicus so that there's no scatter radiation. We've done around 50 in for non-gynecological cancers mainly, colorectal cancers, and 2/3 of the survivors are menstruating, which is a good number. See, this is the subcostal margin, and you can see the liver there. It can go up. It can go up even further. So I make a tunnel. I make a tunnel in the peritoneum and pass this adnexa. Let me make a tunnel in the peritoneum like that, and push the ovarian vessels through that so that they stay inside, not interfere with the bowel, and also it prevents it from falling down. Ovaries are heavy. Remember, ovaries are heavy. These patients need short course CTRT in colorectal cancer, sometimes gynae as well, pelvic CTRT. So push the adnexa through this. This is a laparoscopic method I'm doing. You can do whichever method. Minimal access method is very good for this because you can go as high with your incision, with your open incision. When we used to do Vardhams, it is not easy to push this up and stitch it up at the subcostal margin. Whereas with minimal access, you can go as high as possible. One of the last patients of Ewing sarcoma, I could place it here under the diaphragm. Actually, it could go that high. So I put a stitch as well, so that it gets anchored and it doesn't fall down. We just need 4 to 6 weeks of it not falling down. Now, Dr. Shahana.
Yes. Yes, ma'am.
This is all the main surgeries I've had. We did repair a vaginal fistula post-surgery. Actually, it was done outside and was referred to us. She had nearly a 4 centimeter gap in the means we could pass our finger through her bladder. We did repair it robotically though. It's a useful surgery, but I don't think I need to show this because of lack of time. I've got it, but it doesn't matter. What do you say? It's an easy procedure. You can do it open or robotic. We did it robotic. Minimal access can be done, but I felt robotic was, the lady was very, very happy because she had such a horrible time trying to with the fistula, and she became all right. So I'll end this here. I won't show the fistula. I don't think it's okay. You can do open surgery as well for these patients. What's the time now? It's already 10 o'clock. That's why I was thinking. 10 o'clock Indian time. Any questions?
Yes, ma'am. You are showing all the surgeries through minimal invasive surgery. You are practicing the minimal invasive surgery in your center.
For MIS, for MIS in cervix, you mean?
Yes.
No.
Cervix.
Two things I would like to say. I would not want anybody to do MIS surgery if they have not had the experience for a long time, because they're going to, it's going to be complicated. What less than 2 centimeter tumors, non-visible tumors, still there is this thing, but you should have had experience and you should look at your own results, which I've looked at. It will be published in next 2 to 3 months. If you, what most centers all around the world are doing are, they look at their own results. They have their own hospital protocols for less than 2 centimeter or invisible disease where you have done a leap and there's nothing going on there, and no manipulator and vaginal colpotomy. This anyway. I used to use a manipulator before the LSCC trial, but I used to do the vaginal colpotomy without exposing the disease to the abdominal cavity since 2014-15 anyway. So I'm not using the manipulator now, but this is less than 2 centimeter tumor or invisible tumors. 2 to 4, I'm not doing MIS at the moment. I'm waiting for the RAC trial to come up with the results to see what it is. But I would urge anybody who has never ever done or done less than 10, 15 cases or 20 cases. Generally, I think it's 20, 25 cases before you really become proficient in minimal access surgery, not some 5 or 10. I would urge them not to do, not till we get the results proper. No, you have to be accountable for what you do, and you have to have the learning curve for what you do. So I just for the sake of arguments and talking, there's no point talking about that. You have to act responsibly.
Yes, and for how many size and how
2 to 4,
even it
2 to 4 open now. 2 to 4 is
okay.
open. But I'm
Still
doing
you are doing
endoscopic lymphadenectomy. If the nodes are positive anyway, we are not proceeding with it. See what is happening with 2 to 4 patients. 2 to 4 centimeter is even in our series, nearly I think half of them require radiotherapy because of the Sedlis criteria.
yes.
Half of them have already, like, we do less than 4 centimeters. I don't do more than 4 centimeters. Even them, they have LVSI positive, or they have more than 50% depth stromal invasion, and they end up. So 2 to 4, 100% you have to do open now because of what is happening. Less than 2, if you look at almost all, whether it's trachelectomy data or LAC data or any data for that matter, it's behaving better, or it's got non-inferior this thing, even though the studies were not powered for less than 2 centimeters. If you look at soccer, everybody is saying the same thing, less than 2 centimeters, somehow it's doing better. The only thing is now, whether we really need radical hysterectomy for less than 2, nobody knows. That's why the SHAPE trials and other trials are coming. If we don't need radical surgery at all, the whole point of it was radical surgery was complicating everybody's life. If we don't do radical surgery for less than 2 centimeters, I do not know which route is better. Do we end up doing minimal access or no? I don't know. It takes 5-6 years. I think improve. I would tell my residents, you have to keep your MI skills going. You will be outdated if you do not know MI skills. Please don't even think that the thing will go away. It will not go away. MIS will not go away. Robotic will not go away. These are technologies. Technologies only will improve and get better and better and better, and they train you differently now. Whatever happened in the last 20 years, training is going to be different in the next 20 years. So be progressive in thinking, but at the same time be cautious in what you do to today's patient. Tomorrow's patient is different, today's patient. So I would urge all the residents and training people to keep their MI skills for endometrial cancers. Keep doing all your obese endometriums, pelvic lymphadenectomies, this and that, paraitics. Do that so that your soft skills are still intact. 5 years down the line, 6 years down the line, if 3 trials to come and tell us you can do minimal access for cervical cancer, in other countries they have a mechanism to train them. In our countries, if you lose that little period between 30 years to 45 years of learning a skill, you'll never learn a skill. You'll never learn it because it's difficult. So I would urge you people to keep their MI skills going. Don't do cervical cancer, minimal access. Don't get into controversy in life unless you have your own set of series. You have to have a large set of series for you to defend yourself in all aspects, for that matter. Not just defending, to be fair to the patient, I would say. to be honest, fair to the patient that you are doing a good job. So in that sense, if you proceed, I think we'll all win, both from patient side and training. I'm worried about losing training if we don't teach minimal access. So at least do lymphadenectomy is minimal access, and then do open surgery for Vardhan. Still okay.
Yes, ma'am. There are some questions in the chat box. That is from Ugen, Dr. Ugen from Bhutan. Our questions: follow-up of CS cervix after treatment. Any role of cytology?
No, what we do, I'll tell you our protocol, and also I practiced in Cardiff for nearly 13-14 years. University Hospital.
Institutional protocol.
Yes. Radiotherapy patients, we don't do cytology because it simply gives unnecessary atypias and this and immature cells, and they are not cancer, and they are just because of radiation you get miserable cells looking on in a wall smear. For patients who have not or radiotherapy naive, who have had radical hysterectomies, we do a wall smear. We call them every 4 monthly. We do a wall smear. We do a clinical examination. We don't do any CT scans or anything. And then for 2 years, we call them 4 monthly. After that, we call them 6 monthly. And it's up to you guys. You want to then increase or decrease depending upon how far they live, etc. 5 years. For radiotherapy, it's preferable to follow them up for 10 years because radiotherapy side effects start around 5, 7, 8 years. All their lymphedemas and fibroses and all those things, bladder problems start a little late compared to surgery. So follow up with wall smear for radiotherapy naive patients. Radiotherapy patients, I think it's a waste of time and resources.
Another question is from Namka Durjish. He's from Nepal. How many days do you keep catheter after radical hysterectomy? And do you recommend or practice catheter clamping before removing it?
Okay, two things, depends upon where you practice. If you've done a nerve sparing radical hysterectomy, in developed country where I was, when we were doing it in Cardiff for this thing, we used to remove it in 48 hours, in and around 48 hours. Now I come back to India, and it's not easy because the patient, there's no 1:2 care here, 1:1 care. The retention of urine is not looked at carefully. Sometimes the patients go home, we do not know what is happening to them. So generally for nerve sparing radical hysterectomies, we keep for five days. And then for the ones where we have really done and clamped all the nerves and put our big heenies and destroyed the whole hypogastric fluxes, I would say 7 to 10 days is ideal. At least in our population, the atony of bladder is much higher. Somehow women don't pee do all their lives because either there's no toilet or bathroom, or they're all the time working in the kitchen. So they have atony, our patients. So if you do now, if we kill the nerves, they'll have more atony. So I would keep it for 7 to 10 days. And with regards to clamping and this thing, yes, it is always important because these people come from far off. There's no point just removing the catheter and sending them and they go into a big retention. We do two catheter, we put in to check residual urine. We remove the catheter and check twice on the same day. She comes to the OPD, we catheterize, see if it's less than 100, 150 ml. 100 is a limit, but somehow we moved on to 150, and go ask her to go have lunch, eat nicely and drink and come back, and then put a catheter in again. If at 2 occasions, if it's less than 100 to 150, you can send them. I give an advice for the next how many years she's going to live. For in the morning time, pee 3 to 4 hourly, and in the night 2 to 3 times whenever she gets up in the night, so that the bladder gets back to its normal function, at least in the couple of years. In Cardiff, we were not recatheterizing the patient to check for residual urine. We had a bladder scan. So we used to remove the catheter and then ask her to roam around, and when she and then we used to, remove the catheter and do the bladder scan and get the 100 ml, less than 100 ml in 2 occasions and send them home. The problem in I tried getting a bladder scan, but there is obstetric problems. You can't have a scan roaming around because we might do fetal testing of male or female babies in the ward and we might get into trouble. There's a lot of controversy in owning a scan machine in a hospital other than the ultrasound people, radiology department. So somehow we've not managed to get the bladder scan. If you can in your country get a bladder scan, there's no need to put the catheter back in to check the residual urine. That's the best way. Anything else?
But I think sometimes it may be the surgeon's choice. If there is more dissection, then I think the catheter should be kept in there are many days, and if the dissection is not so extensive, in that case, we can remove the catheter. I think it should be the surgeon's choice.
Yes, if I've done a type 3 radical hysterectomy non-nerve sparing, 10 days, easily 10 days. Some people keep it for 14 days, but then they end up with infection and antibiotics and too many things going on. 10 days, you remove it and check for residual urine, and she's doing well. I think most of the times you've done, they generally recover. There are 20% of the women at 10 days when you remove the catheter, they're still going to atony, and the urinary, the residual urine is more than, then you can keep. What happens with us is we discharge that. There is one more problem we have in our own hospital is we discharge the patients around 4 or 5 days basically with the catheter, and we send them home, nearby Tata Memorial wherever they stay. Now histopathology comes around 2 weeks for us. So to get a patient to come back to remove the catheter on one day, and then get a patient to come back for histopathology becomes difficult. So in and around 10, 12 days, they come. Whenever they come, we remove the catheter, whenever the histopathology is ready. But it's definitely between 10 and 15 days, not more than that.
Another question is, what will be the treatment options for local recurrence following radical hysterectomy?
For local recurrence, in terms of vaginal recurrence, a small standard teaching all many years is a small recurrence on the wall. You can exenterate the patient as long as the lymph nodes, the pelvic lymph nodes are negative. This has been standard teaching for last, I think 30 years I've been practicing. That was a standard indication. But to get a small growth on the vaginal vault is very rare in a CS cervix patient. Very hardly you see one in a year or two in 1 year, just a little tiny dot sitting there and saying hello to us. Generally, patients come with a big disease, post-recurrence or residual disease post-RT. So that indication is very standardized. But now if you look at the layers are done for parametrial involvement. Lateral extended resections are done for parametrial involvement. Preferably small disease, volume disease, and parametrial involvement. If you do a layer, you might give them DFS and OS. So it can be tried. There is a learning curve for layer. It is not as simple as it appears on the video. There is a learning curve. You need to check the anatomy. You need to go for cadaver courses. You need to see what is there and where is the lumbosacral trunk, first of all, in that pelvis without injuring the interiliac vein. So a layer can be done. Now, if you look at 2-3 years back, ESCO presentations, even when the obturator internus muscle is involved, people are moving and removing all that and coming out. So the indication for exenterations is increasing. So the last 3 weeks back, I did one layer, but the cervix was absolutely fine, but she had disease just on the vagina. The vagina, I thought I might get away by just doing a layer and a radical hysterectomy and come out, but ended up doing an exenteration for her in the end, because the bladder was tearing and the growth was almost going up to the bladder, even though the mucosa was not involved. Colorectal surgeons, all this extrapolation which are being presented in ESCO-ESMO conferences are coming up because of colorectal surgeons. It's a good biology disease for colorectal surgeons, and they're going lateral and removing things. So gynecologists are trying to adopt from colorectal surgeons. Even Prof. Sibila was saying that we learned from colorectal surgeons how to go completely lateral and get up to the sacral bones to get the disease out. Let's see. It is these are all feasibility things which are happening in the world depending on the surgical expertise and the type of biology the patient has had. So if a patient comes within 1 year of having CTRT, I think it's a waste of time, because the biology of the disease is so bad that she's developed a large disease in the vagina and if she comes at 2 to 3, 4, 5 years, I think fair enough, you can try something. If it gives 2 years DFS or PFS or survival, it's good enough. I think it's good enough. No standard answers for such things, because there's no standardization of these things.
Okay, ma'am. Okay, thank you very much. Thank you for your elaborate, nice presentation. Now there is Dr. Mohiuddin from Canada, radiation oncologist, wants to make a comment.
Yes.
Shorna, you please co-host Dr. Mohiuddin.
Do practice go.
Hello.
Hello. Hi, sir.
Oh, thank you, Lutfa Lipi. It was an excellent presentation. Because my lunch time, I was watching. It was excellent and very encouraging for Bangladesh that we have now, gynae oncology department. I was the other day listening Professor Jonaki's presentation on cervical cancer. So it's very encouraging. But one thing in Lutfa's presentation, she mentioned about the take-home message. I think we must take it seriously about the multidisciplinary meeting. So we, as a gynecologist, radiation oncologist, radiologist, and cytologist, pathologist, we should have, official monthly or bi-weekly multidisciplinary meeting. Here we do the same thing because what I think, India, Bangladesh, Bhutan, Nepal, our region must lead for the cervical cancer because the number is very, very high. In Canada, I see only 1 or 2. In our department, we see 6 or 10 patients per year. So that experience is not going to help. So all the protocol or, come from that side will be helpful, And if in Bangladesh with the, now the specialty is growing, so there need a collaboration with, all the other team, and it will help us a lot. Thank you very much.
Agree.
Thanks, Dr. Shalestri, for your presentation.
Thank you, sir. Thank you very much. I always invite you, but today I see you, sir. Thank you very much, sir, for attending our program. Thank you, sir. Tamal bhai, do you like to comment?
No, it was so educational. I was just listening and learning. It is better to be a listener and learner than making a comment.
Thank you.
So, what we can say that what I liked in the presentation, that what we can do that is important, but what we should not do that is more important. And we should not be adventurous. In the total presentation of Shailustri, she was always telling so many things, but I was observing as a non-surgeon, she was putting caution to the listener and observer that where they should be cautious, where they should not do some harm or injury. I think that is the main message, that with a knife or you can cut many things, but how much is required, that is important. To save the other structure is more important than cutting the required thing. I think that is the most important part. And what Mohittin Bhai was referring, I think that is the main essence, that today in the era of organ preservation, there is no ego, no me issue. We issue should work. No me or I is the issue today. So we all should sit together, find out what is best and what can offer the best result that should be offered. Either it's a surgery or it's a radiotherapy, whatever is suitable. And another is what is possible. So what Dr. Shalustri is doing in Mumbai may not be possible to do it in Bangladesh. So we should not be jumping in after seeing the video to attempt. We should have adequate exposure, knowledge, training, and confidence before jumping into that. I think what she was trying to tell at the end, the n number of cases should be done before entering to this. I think these are very important messages. We should not take the piecemeal message of the presentation. We should listen to the whole thing and take the message. So I think, Shahana, that was a great session that we listened. And what is the objective of this session was the mentoring session that you said. We wanted a local mid-level or junior should make a presentation, then listen to a senior that what they want to talk, so they can understand where they can make the improvement. So this is how we can develop our faculties and who are the future of our country, not only as a clinician, but also as a teacher and a presenter. So this is how we are clubbing together, and thanks again to our regional friend Shailustri and extra regional friend Mohittin Bhai for supporting us in this our endeavor.
Thank you.
Another small talk I can tell, I'll take the liberty to tell it because this is the 50th anniversary of our country. But unfortunately, we do not have cancer registry. Only National Institute of Cancer Hospital, they have hospital-based registry. If you look at the Globocan, the number of cervical cancer in Bangladesh, this says 8,268, but I'm not convinced with this number. Because if you look at India, they have so many local, regional, district, hospital-based cancer registry, unbelievable. So at least oncology club or even gyno-oncology, if they start their own cancer registry, it will be the beginning, you know. And I think we need this cancer registry. And you know that our at least 2.8 million female who are 30 to 50 years old working in garments factory, they will be the good resource for us as well for you know, start the national screening program as well for via, although it started, you know, from BSMMU, but we need a national screen program. Thank you.
So Mohideen bhai, just for your information, thank you for the suggestions. Registry, you know, it's a huge thing. It's a big thing. Oncology Club is a small partner, and we cannot go for the national registry, but we have to.
No, local.
Professor Hai has started an endeavor to gather the data from different sources. He developed a program, and we have started it. But we are always asking the government and the, you know, the bigger platform to start the national registry, which is yet to be started. But we are trying to make something like in between population-based and hospital-based. So we are trying to gather the data of different population hospital-based registry to go for a national database, not a registry, I will rather say. And regarding the that you said that what we are lagging behind, yes, we are lagging behind, but we are slowly proceeding, and we are hopeful that we can really go forward. And regarding the Globocan data, unfortunately, we are using the Globocan database. You know, personally as oncologist, I cannot depend on it because they said esophageal cancer is the highest in our country, which is really unacceptable. But you know, they have their own tools of finding is, as we don't have a registry, so we need to base on that. So looking forward, hopefully, maybe very soon we will have our own data, and we have many people are working on it. And thanks for the suggestion. So Shahana, I think we can wrap up.
Yes, thank you, Dr. Shalini ma'am. Thank you very much for this elaborate and the long presentations. And I think all of us are very much grateful to you for your today's presentations. And I request Shorna to show your poll questions again, and the participants are again requested to voting in the poll sessions.
So Shahana, is it the last of cervical cancer series?
Yes, yes, it is the last, and we request that all the participants are requested that today is the last sessions of the cervical cancer lecture series, and the next session, that is it is around, I think it is 3rd April. We want to arrange a whole day workshop and carcinoma service, and I think Dr. Shalini ma'am and other the faculties will request you all from on behalf of the oncology club to attend in that session. And all participants are requested to attend the sessions.
So that will be a session, Shailusri, where our local presenter will present again. And this time we will see how much they have learned from you, how much they have improved. So it was like a back-to-back program, and where we will be, we will be watching with you the development and the outcome of this total series of endeavor. So there we will have some lectures, and also we will have some case discussion type of sessions from all the medical colleges. So we will make the mixture of lectures and problem-based discussion, where we will encourage the local to present and faculties, overseas faculties to interact. So hopefully it will be a good interactive session, and advance invitation to you, Shailusri, to be there.
Thank you. Most people have answered the right question. 85.
Yes, right question is section now. Only 1%, that is 3%, they have answered the right question. The second question. So it is, they have a guess, 85% they have. Yeah. The second question, a patient under modified radical hysterectomy for stage 1A2 for cervical cancer. It included all of the following steps except resections of the parametrium from its pelvic attachment and the removal of the upper 1/3 of the vagina, bilateral pelvic lymphadenectomy, and ligation of the uterine artery when it crosses the ureter. Okay, 77%, so this is the right answer. Then the third question. Yes. Indications of the cold knife conization includes carcinoma in situ, stage 1A1 cervical cancer, atypical glandular cells in cervical cytology, or all of the above.
I had one suggestion for cold knife for residents.
Yes.
Doing a knife cone biopsy is not easy. That's all I can say, because you're carving, right? If you don't have the beveled knife, you'll be carving the cervix, and sometimes you take more than necessary, and sometimes it doesn't come nicely. It doesn't come beautifully. So what I learned abroad was we used to do a lot of knife cones before I left India and went there and came back. A loop, the leap biopsy with a cutting current. Don't use the you don't use the mixed current for cutting. Generally, we use a mixed current when we are doing a normal leap biopsy for CIN3s and all. For this, you just use a pure current. Keep the ball electrode ready. Use a pure current. Don't stay too much. Go core the cone as a cone. Get it out and do the like exactly like a leap biopsy, but with a pure cut. Use a pure cut. Then your diathermy margin won't come as it will not interfere with your histopathological, and it's beautiful, and you will not go close to the interloss because it won't allow you to go. So I personally feel cold knife is overrated. It was taught to us from the beginning as beginners, but I think it's overrated, and most people end up doing a bad job of like a scrambled egg. The cervix comes out sometimes when people do cold cones. So knife cones, I meant. So be careful. If you are experienced, good, fine. Otherwise, just do a leap, nice leap with a cutting current.
Okay, postmenopausal lady.
You get small loops. So
Yes.
we used to use the small loops because the cervix is so small.
Yes.
Postmenopausal lady, most of the times we end up doing hysterectomy for them. Very rarely we do a cone biopsy. Second thing is very flushed cervix. It's very difficult to do anything anyway, whether you do a cone or this thing, because you'll be entering very close to the uterine artery, and cervix is too close. So the uterine artery is just starting off at the lateral edges. So in them you can use a very small leap, or do a hysterectomy, I would say, preferably. Even
But
vaginal.
if there is a confusion where it is the carcinoma in situ or in invasive disease, in that cases, we must have to rule out whether this invasion. For that reason, we should go for the before hysterectomy.
Most of the times, a leap cone. Very rarely we have gone ahead if I can't do a leap cone with a cold cone under anesthesia and then tried. Very rarely. But that is also both of them are difficult in an old lady with a very postmenopausal thin cervix, small cervix.
So, Shorna, please show the winners.
Yes, ma'am.
For the winners.
Yes, there is the Hena Borua. She's from Rangamati. That is, it is our hill tracks. And second winner is Maksuda Parveen. And third one is Jannatul Firdaus.
Well done. Knowledge is power. Knowledge is power.
All the three winners are requested. You please unmute yourself and on your video. Otherwise, if you are not interested to do that, you please put your phone number in the chat box. Otherwise, we cannot communicate with you, and we can. Yes, Hena Borua. Note the phone number. Yeah. Maksuda Parveen, you are from? Dr. Maksuda Parveen? She is not responding. If you don't respond, we cannot give you the the prize.
What prize are you going to give?
We are going to send some.
Just token money. Come on, bhai.
Yes.
Do you like to comment?
So every time we send some money.
Oh, very
Money,
good.
token.
Lovely.
Yeah.
Somebody is rich, they don't want money.
Probably. Especially, you know, the GYN ops guy, GYN practitioners, they don't, I mean, they are quite usually they are,
Obstetricians don't need money.
yeah.
Good. Very good.
Okay, thank you, ma'am. Thank you very much for your the whole night. And tomorrow you have the office. We all know. So you were so late, and we are very much grateful to you all. And we request you for our next sessions that we think that you will be with us. And I request the all participants to attend the full day workshop in cervical cancer on 3rd April.
From surgical point of view, we should concentrate on surgical skills learning somehow, some cadaver courses. We have to get them skilled. That is the one thing which is lacking in our countries, both India and we have to get them skilled. Surgeons have to be skilled, then we can talk on equal terms. Knowledge we can acquire from somewhere, but skills have to be acquired by just doing and doing and doing and doing and doing. Then we will not mismanage patients. That's my take-home message for surgeons. The rest of it is fine. Thank you. Thank you.
Yes, ma'am.
Thank you very much. Namaste.